My name is Glenn Keeling. I'm with HipecTreatment.com, and we're pleased to sponsor tonight our live virtual group discussion treating advanced colon cancer, appendiceal cancer, and ovarian cancer with CRS plus Hipec. Our featured speakers tonight are Dr. Ryan Merkow, a surgical oncologist at Northwestern Memorial Hospital, and Dr. Edward Tanner, Chief of Gynecological Oncology at Northwestern Memorial Hospital. To start the discussion off, I'd like to just ask Dr. Merkow, what is CRS and Hipec? What does that mean?
Sure. So CRS stands for cytoreductive surgery, and Hipec stands for hyperthermic intraperitoneal chemotherapy. They're almost always combined. Cytoreductive surgery refers to an operation where a surgeon goes in into the abdominal cavity and tries to remove all visible disease that is present. Sometimes that disease is just along the surfaces of the inside of the abdominal cavity. There's a thin tissue paper-like structure called the peritoneum that really covers almost everything inside the abdominal cavity, the walls, the diaphragms, the liver, and also most of the organs. And so a disease can set up shop in that structure, that peritoneal structure. So a surgeon goes in and attempts to remove all of that disease. Sometimes that means just stripping that lining. It's almost like you can think of it as an internal skin, but stripping that lining. Sometimes that's all it takes. Sometimes that the disease is actually on that lining, but involving different organs inside the abdomen. And so if the disease can't be completely removed with just stripping the lining or just removing the disease, sometimes the organs have to be resected. A surgeon who is experienced at this procedure knows what is safe to do, what can be removed safely, and what will cause long-term problems with quality of life and that sort of thing. So it takes a lot of experience to know what you can do. Then once that is complete, Hipec refers to circulating heated chemotherapy inside the abdominal cavity. It's actually the most straightforward part of this entire operation. The surgeon will place cannulas or tubes inside of the abdomen where the abdomen is temporarily closed, and then a heated water bath gets circulated. And then once it's all set up, the surgeon will put in chemotherapy. Depending on the disease process, there's different types of chemotherapy. For most GI-related malignancies, it's a chemotherapy called mitomycin C, but that gets circulated for about an hour and a half, and then it all gets removed from the abdomen, and then generally the procedure is completed after that.
Okay, Dr. Tanner, what are the situations where you would use Hipec?
Yeah, so just to echo what Dr. Merkow was saying, the general principles of the cytoreductive surgery, debulking surgery, where we're stripping this peritoneal lining or removing organs that might be necessary, are pretty similar regardless of what type of cancer it is, whether it's appendiceal, colon, or ovarian cancer. Right now, for GYN cancers, the kinds of things that I treat as a GYN oncologist, really we're only using Hipec for ovarian cancer in patients who have received chemotherapy before surgery. There's a lot of interest in expanding the use of Hipec for other situations, for patients before receiving any chemotherapy at all, and also for patients, perhaps down the road who might get Hipec if they have a recurrent cancer. But right now, we're using it primarily for patients who have gotten chemotherapy, who've had a good response, and then are going to surgery for what we call an interval cytoreduction. And we do use a little bit different measurement. We use a drug called cisplatin, which is similar to carboplatin, which is a drug that most patients with ovarian cancer get through their IV. And so we use that very similar amount of time, and otherwise the equipment and the process is essentially the same as with appendiceal and colon cancer. So right now that's the main indication where we're using Hipec for ovarian cancer.
Now, how do you decide who is a good candidate for this procedure?
Yeah, so the most important thing is that someone's has resectable disease. So Hipec is given with cytoreductive surgery. So we want to make sure that we can remove all or the vast majority of the cancer. Part of the way Hipec works is penetrating microscopic or very, very tiny residual nodules of tumors. And so it doesn't work, it can't penetrate larger masses. You have to remove the larger cancer first and then penetrate the smaller disease. So it can't be done if there's disease that can't be removed at the time of surgery. So patients who have ovarian cancer that get chemo and have responded enough that all the cancer can be removed, those are the best candidates for Hipec. And then, more general ideas about just medical health and that someone is well enough to undergo a longer surgery. But in the trials that we've looked at for ovarian cancer, there's some concern initially that perhaps the patients who underwent Hipec had, might have a harder recovery, but actually when we select patients well, they actually do just as well in terms of recovery as patients who just go the debulking or cytoreductive surgery by itself. So really, if a patient is a good candidate for an interval debulking surgery and doesn't have disease outside their belly, they're probably a good candidate for Hipec as well.
Okay. Dr. Merkow, what about candidates on your side as far as colon cancer and appendiceal cancer?
Yeah, so the main patients that I treat with cytoreduction Hipec are those who have colon cancers and appendix cancers, and also another entity called low-grade appendiceal mucinous neoplasms, which are they originate in the appendix and they spread to the abdominal cavity. Those are the main groups of patients that I treat. In terms of patient selection of who would actually benefit from this procedure, which is really the bottom line, a surgeon never wants to do an operation if it's not going to change the trajectory of the disease course. So patient selection is really key, is really important, which is probably one of the hardest parts actually of treating patients with this disease. And it takes a lot of experience, which where most of the training comes in is actually in that first part is patient selection. But for patients who have a true malignancy, not the low-grade appendiceal mucinous neoplasm, those patients are getting chemotherapy first, almost all the time. We use chemotherapy, number one, to treat the disease. This is a systemic disease, so we want to treat the disease that we can see on scans, but also the microscopic disease we can't see. That's what the systemic chemotherapy does. If they respond well to that over time, they don't have disease progression and they don't have metastases and solid organs and in distant locations like the lungs, and it's primarily just located in that peritoneal lining, then we will consider those patients for cytoreduction Hipec surgery. Like Dr. Tanner said, the key thing is making sure that you can completely or nearly completely remove all visible disease, and that's really fundamental. We believe that the Hipec therapy treats small residual nodules that are less than 2 millimeters. So, but the goal really is to try to get a complete cytoreduction, and so we often perform laparoscopies before cytoreduction Hipec to evaluate the inside of the abdomen to see if they're a candidate for this procedure, if they have disease that is located in areas that I believe that can completely remove. And so that's a key component to patient selection. The other big group of patients that I treat are those with low-grade appendiceal mucinous neoplasms. That's a mouthful, so we just say lamin for short. So lamin can disseminate into the abdominal cavity, and though that's a very low-grade disease process. And so we don't believe actually that chemotherapy is beneficial to those patients. Chemotherapy through the IV is beneficial to those patients. So we will go down the pathway of initial cytoreduction Hipec surgery if, again, I believe that I can safely remove all visible disease and then treat with the Hipec part of the procedure. So those are kind of the main concepts, big picture concepts that I use when I'm selecting patients for this procedure.
Okay. We have a question coming in from our streaming audience now. How was this developed and when was it developed? Meaning Hipec.
Well, it's been around for a long time. That's an interesting question. And we could probably talk for a few hours on the history of this procedure, but it's surprisingly been around since at least the 80s, maybe even before that. And it was developed back when we didn't really have a lot of options. We didn't have a lot of systemic options, and it was very experimental back then. But surgeons and oncologists figured out that in a select group of patients, it could actually be very beneficial. And so it has been around for a long time, and there's been lots of studies, trials that have looked at this procedure, and it's really helped us hone in on which patients we think can benefit the most from this therapy.
Okay. Dr. Tanner, what are the side effects of this procedure, Hipec procedure, during ovarian cancer? Are there any, or is it during the surgery or after the surgery?
So it can be hard to kind of separate out what are side effects from the cytoreductive surgery from the Hipec. So cisplatin, the chemotherapy drug, we use it all the time for lots of different types of cancers and giving it through the IV. When we use it in other settings, it can affect the kidneys and also can cause nausea and some neuropathy, so numbness or tingling in the fingers or toes. But when we give a single dose of it in the belly, the patients are getting hydrated. We actually give a medication that supports the kidney function when we give the cisplatin. And in my experience, and also in the really well-designed studies, if you pick patients appropriately, we don't really see a lot of extra toxicity from the Hipec. The cytoreductive surgery is quite variable. We have some cases where we go in after chemo and someone has almost no residual disease, and we're just removing the ovaries and the uterus and omentum and then doing the Hipec. And then there are other cases where we have to do multiple bowel resections or removing spleen or part of the liver. Sometimes I may call Dr. Merkow in to help with some aspect of that. But a lot of those procedures have risks and side effects from them. So sometimes it can be hard to kind of tell the difference between those two things. But overall, in the best quality studies where patients are really well selected, there doesn't seem to be a lot of extra toxicity from it. But recovery from debulking surgery can be challenging for patients. But it's important to recognize that, in the studies that have looked at Hipec for ovarian cancer, that it has shown a significant improvement in survival for patients. At least a year in the best trial that was published a couple of years ago that led to Hipec becoming a standard of care for patients. So, there has to be some trade-off of risk versus benefits. But overall, I think for patients that are doing well and have good chance of getting all or most of their disease out, that the toxicity, the added toxicity to Hipec is not particularly significant for the kinds of patients that we're using it in for ovarian cancer.
Glenn, I would just add to that. I completely agree with Dr. Tanner. There's a lot of, I think, misconceptions and kind of mystery about the Hipec part of this procedure. I get a lot of questions about it, and I try to sort of ease people's minds about what it actually is. It's pretty simple. It's essentially circulating some heated salt water that we mix in some chemotherapy, different types of chemotherapy, depending on the underlying disease process, for a period of time, which is actually pretty straightforward. What's variable is that cytoreduction or debulking component, and every patient is different. Every patient has different disease patterns. There's different extent of disease. Even the disease itself can have different characteristics. Sometimes it's more invasive, sometimes it's more nodular, and it's easier to come off. So there's lots of variation there, and the risks of the procedure and the recovery after surgery, most of it is really from that cytoreduction part. What organs have to be removed, those types of things. And so I try to counsel patients, and I try to really provide a good idea of what sorts of things I think I'm going to have to do during that cytoreduction, with the caveat that once you're there and actually doing the procedure, you may find additional disease, but you may find less extensive disease, and so you make some decisions during that procedure about what you have to do. But it can vary extensively from patient to patient.
Yeah, and I think that one of the other things that we, at a high volume cancer center that we almost take for granted is the quality of the other kinds of services that are part of comprehensive cancer care. So, perioperative care, expert anesthesia care, nurses that are used to dealing with patients with complex issues. We have an enhanced recovery protocol that's very streamlined and evidence-based. So a lot of parts of perioperative care, so like the things that we do in the operating room, other than the surgery itself, like the medications we give and how patients recover, has really been revolutionized over the last 5 to 10 years. So I do think that maybe some of the earlier reticence and problems with Hipec were really related to the fact that we now take better care of patients as they recover from surgery. So they can tolerate, more complex procedures and things like Hipec without, as many complications. So I think that's probably another big part of it is the comprehensive expertise that, in centers that take care of a lot of patients who undergo Hipec and cytoreductive surgery that, is really a critical part of this, as much as the expertise of giving the Hipec and making decisions about who's a good candidate, but also the perioperative care, which is so important for the patients too.
Okay, thank you, Dr. Tanner. We have a couple questions coming in from our audience, and Dr. Merkow, I'll address this one to you. My question is, there's still some tumor neuron on the blood vessels near the liver. As of now, my wife is doing great, but the concern is that 5% is still there. Two questions. Is it possible to remove tumor from those vessels, and would Hipec be helpful?
Good question. I think the answer to that question is based on a few things. What the nature of the actual disease, the underlying biology. Is it a higher grade malignancy, or is it the first component that I talked about earlier, the low grade Dependency neoplasm? Treating those two different clinical diseases would be very different. If the disease can be safely removed and it's in that peritoneal surface, then and there's no other disease in other locations like solid organ metastases, liver, lung, that sort of thing, then it might be worth considering it. But it's really in those details of what exactly is going on. For patients who have the low-grade Dependency neoplasm or lamin, we will often follow disease over time if there's just a small amount, especially if it's on very critical structures that would be dangerous to try to remove the disease from. And so oftentimes I will watch disease for years, and it sometimes never changes actually. And so I'm more careful with those patients, especially if there is a significant risk to the actual procedure.
Okay. This next comment comes in from my brother had both the cytoreductive surgery and Hipec done by Dr. Sardi at Mercy, Baltimore. But after much internet searching, he found that this is an option on his own. No doctor ever told him about this option, nor did his doctor know that it was an option. How can we get the education to the hands more of the physicians? Again, my brother was a self-referral to save his own life. And I guess that's a appropriate question, since there's probably what, Dr. Merkow, Dr. Tanner, less than 200 surgeons in the United States currently doing this. So would you like to comment on that?
Yeah, that's a great question. I think the answer to that is sort of several different ways to think about it. I think on one hand, there's I think there's just a lack of knowledge and understanding of the procedure itself, and that it's an option in which patients might benefit from that procedure. And so oftentimes surgeons do not get referrals, or patients don't get referred on to specialized centers that are familiar with this disease and patient selection. And so I think that's part of it. I think there's also some misconceptions about the risk of this procedure. I think especially early on, when it was first being developed, and patient selection was probably not entirely appropriate, or was more aggressive in this. Operations were more aggressive. There was a lot of risk, actually, and early on, actually, one of the trials in Hipec, there was a mortality of 10%, which is unheard of these days. There's no center that's experienced with this procedure that has even close to a mortality of 10%. So I think it was early on that led to a lot of misconceptions, and probably some fixed false beliefs about the potential benefits of the procedure. And so I think a lot of patients never hear about it. I'm still getting lots of self-referrals, patients who've just done their own research, have become their own advocate, and referred themselves over. So I think doing things like this, publishing as much as we can, getting the word out in our communities among medical oncologists and other surgeons about the potential benefits, and making sure those patients get referred on to an experienced center. I think those are all very important things.
Okay. Dr. Tanner, we know you're treating ovarian cancer. Are there any other GYN cancers that can be treated with Hipec?
Yeah, at this point, there are not any other GYN cancers where we have high quality data to support using Hipec. I think that there's a lot of interest in considering whether Hipec should be given either to patients before starting chemotherapy, or also in patients who have recurrent ovarian cancer. That's probably the area of most interest, because it's kind of a question of applying more broadly what we're doing already. For uterine cancer, there are particular subtypes of uterine cancer called serous carcinoma, which is the same as most ovarian cancer. It's not approved for that indication at this point, but I think there's a lot of interest in eventually applying these to other types of cancers. There are some rare situations where patients may be appropriate for a Hipec procedure, like a low-grade mucinous tumor of the ovary that kind of mimics an appendix cancer, but most of those things are really considered on a case-by-case basis. But really, the area where there's high quality data to suggest that Hipec is appropriate is just in the ovarian cancer after primary chemotherapy. But really, this does get to that question, the previous question about getting the word out about the latest advancements. The Hipec was approved for ovarian cancer a little under 2 years ago, and it's still kind of getting out into the community, but probably is still best to be considered in high volume centers. I think more broadly, ovarian cancer surgery and debulking procedures tend to be, patients tend to have better outcomes when surgeons do these kinds of procedures all the time. So it is important to get the word out for the right patient, that they get to a place where they can get, the absolute standard of care. So that's very important.
Now you're administering chemotherapy in the cavity. Are there side effects of the chemotherapy? Are there normal side effects by these patients? They lose their hair, et cetera, or what are the side effects of the chemo?
Well, it's a little hard to, so we give cisplatin in the abdominal cavity, which is very similar to carboplatin, which the patients are receiving anyway. Almost all of them will have received carboplatin IV. And so there are some issues like nausea that can happen. Of course, that can also happen after surgery, or some kidney issues, but we watch really closely for that. And we're not really seeing issues with like kidney failure or anything like that in patients after they receive cisplatin. We do see that sometimes we give cisplatin in other contexts, like not in the belly, but we're not really seeing much of that. I think overall patients really have very few side effects from it, other than what we would expect to see as they recover from surgery. Certainly, there's other things with chemo like low blood counts, but those don't tend to happen very often, or at higher rates with the Hipec than just when patients have the surgery by itself.
Dr. Merkow, the patients you treat on the GI side for the colon cancer and appendiceal cancer, do they receive chemotherapy before the surgery and after the surgery, or they just get the Hipec?
So, it's a little bit different than the way we treat some other types of cancers that are non-GI. So it depends on whether or not it's a malignancy or not, whether or not it's a low-grade appendiceal mucinous neoplasm or not. Those patients, like I mentioned before, we're not treating with systemic chemotherapy. The other group of patients, those who have appendix cancers, colon cancers, those patients do get chemotherapy, systemic chemotherapy, but it's not perioperative chemotherapy. It's not chemotherapy at the same time as the cytoreduction and Hipec. They usually get chemotherapy prior to the procedure. We are often giving 8 to 12 cycles, depending on the clinical scenario. But then they get a chemotherapy holiday, which lasts at least 4 weeks, sometimes 6 weeks, so they can recover from that. And then we do the surgery, and then they recover from surgery. And oftentimes they're done with chemotherapy, just depending on the clinical scenario and how successful we were with the cytoreduction Hipec procedure. So that they're not getting systemic chemotherapy at the same time as the procedure. I would add too, just to add on to what Dr. Channer was saying about the side effects of chemotherapy, the Hipec chemotherapy, and in my case, usually it's mitomycin C, not always, but very similar to ovarian cancer therapy. There's very few side effects to the actual Hipec component. We believe that the majority of the risk, the morbidity, the complications that can occur, and the recovery process afterwards is really influenced by the cytoreduction part of it. The mitomycin C, relatively large molecules actually, and they don't get systemically absorbed very much, if at all. So sometimes we'll see a little bit of lowering of the blood cell counts, but generally there's very minimal systemic effects from that chemotherapy. We consider it something called a regional therapy. There's lots of different types of regional therapies. I treat other patients with a special regional therapy that treats metastatic colorectal cancer or appendix cancer to the liver only. That's a regional therapy where chemotherapy is delivered just to the liver. In this case, chemotherapy is just delivered to the abdominal cavity, the inside lining of the abdomen, sparing other normal tissues and the rest of the body the potential side effects from that treatment. And so that's just an important important point. The whole purpose of this therapy is to treat the location or the region of the body that has the disease and sparing the rest of the body the potential side effects.
Okay. This is our final question for you, and this is to both of you. What new innovations do you see coming down the pike for Hipec and the treatment of what's the future?
I can start. There's some, there's some really fascinating studies and experiments that are going on out there where scientists are looking at different ways to deliver the chemotherapy into the abdomen rather than circulating chemotherapy, treating the abdominal cavity with sort of like a gas, so to speak. So it goes in and it sort of covers the abdominal cavity and treats the disease. And so there's different ways of delivering the chemotherapy, which is very interesting. And there's nothing that is readily available right now, at least in the United States. But I'll be looking forward to seeing more data from those studies. There's different ways of delivery. There's different sort of sequences in terms of delivery of the chemotherapy. Right now we're sort of just doing it once, where you can imagine a scenario where you could deliver it more frequently over an extended period of time to try to get more benefit from the regional therapy component, and so I'll be looking forward to studies that are focused more on that. Those are kind of the main things that I'm looking forward to.
Yeah, I'd say similar. There's also some studies for ovarian cancer looking at the heated gas. Read some case reports about using Hipec in the chest cavity for ovarian cancer. I mean, these are all still experimental things. And then also for us, like, using carboplatin, which is the drug we conventionally give, is kind of compelling. But again, we really need to have high quality studies to make sure, especially now that we have cisplatin as a standard, to make sure we're not compromising the effectiveness of it by using a different drug. So, there's been a lot of hard work to establish Hipec as a standard for ovarian cancer. So we really want to make sure that we don't substitute for something else that might not be as effective. And that's why the studies really need to be done to do that.
Okay. Well, we don't have any more questions coming in from our live stream audience. So I want to thank Dr. Merkow and Dr. Tanner for their time and great presentation. And we look forward to talking to you again. Thank you very much and have a great evening.
Great. Thank you, everybody.
Yeah, thanks a lot.
Okay, bye-bye.